Good day. I am Dr.K Gireesh, physician, neurophysician and neurosurgeon. And on behalf, this is a part of a continuing medical education program organized by Padma Clinic and Nursing Home, Chennai. And in this is to create an awareness about neurological ailments to doctors per se, as well as to the general public. And in this, it's mainly focused on students who are interested in neurology. The topic for today is the significance and the elicitation of neurologic history. Now, history taking, even in the modern era, is very, very important. To cite an example, about a week ago, I had seen a young individual around 20 years. He came with generalized tonic-clonic seizures, repeated attacks, and immediately we started off the anticonvulsants, and the seizures were brought under control, but he was unconscious. A careful history from the parents of the particular boy, we came to know that he had been working very hard for nearly 3 days and hardly taken any food. Immediately, we checked the blood sugar and we found it was only 20 milligrams. We gave 25% dextrose, 2 bottles were given, and immediately he started recovering and the seizures were brought under control. So, taking a neurologic history is very, very important, whatever may be the neurologic ailment. A good clinical history often holds the keys to diagnosis. This is true in the medical history, surgical history, and the psychiatric history. It's especially true in the neurologic history. A skillfully taken history with a careful analysis and interpretation of the chief complaints, and of course the illness, will very frequently indicate the probable diagnosis even before physical, neurologic and laboratory examinations are carried out. Many errors in diagnosis are due to incomplete or inaccurate histories. And one elicits the symptoms. Symptoms are the subjective manifestations of the diseases as related by the patient. That is what the patient tells. And signs are the objective manifestations which are elicited in the physical examination by the doctor. The taking of the history is not a simple task. It may require greater skill and experience than are necessary to carry out a detailed examination. Time, diplomacy, kindness, patience, reserve, and a manner which you convey interest, understanding and sympathy and empathy are all essential when you are taking a neurologic history. The history is best taken in privacy with the patient comfortable and at ease. An appearance of haste should be avoided, like being in a hurry. No, shouldn't do that. The history should be recorded clearly and concisely in a logical, well-organized manner. It can never be sufficiently complete and no symptom may be left unanalyzed. Each statement must be considered in its relationship to the whole of the patient per se. The essentials of the history should be obtained from the patient himself if at all possible, and he must be encouraged to give a detailed account of his illness in his own words. That's very important. He must be encouraged to give a detailed account of his illness in his own words. The patient should be allowed to use his own words, and any suggestion of symptoms or diagnosis should be avoided. That means an open-ended question is what has got to be taught. During the taking of the history, the examiner has an unequaled opportunity to study the patient, his manner, his attitude, his behavior and emotional reactions. Now, all these can be studied while you are taking the history or while the patient narrates the illness. The tone of the voice, the bearing, the expression of the eyes, the play of the facial muscles, the appearance of weeping or smiling, the presence of a pallor, blushing, sweating, patches of erythema on the neck, furrowing of the brows, drawing of the lips, clenching of the teeth, dilatation of the pupils or rigidity of the muscles may give information of very great importance as you are taking the history and as you are observing the patient. The examiner must of course be very careful not to make do not have a preconceived notion that this patient is suffering with this. No, have an open mind as the history is being taken. The patient's story may not be correct all the times, but of course jot it down. Well, history taking is an art. It can be learned partly through reading and study, but it is completely acquired only through experience and repeated trials. The ability to elicit a satisfactory history is one of the prime requisite to a proper neurologic diagnosis. Now, let us see the general outline of the history. The neurologic history is as true of all the clinical histories. It usually starts with the patient's name, sex, age, date, place of birth, residence, the marital status, occupation and handedness. And under certain circumstances, it may be necessary to inquire about the nationality, race and the religion. Then one records the patient's major or the presenting complaint. This is followed by a detailed description of the symptoms and the cause of the present illness in a chronologic account of its development. Very important. The past medical history will then be outlined after the present history. And there you have a record of the serious illnesses, operations which the patient had undergone earlier, or there is a history of injury, history of birth and early development, detailed account of symptoms referable to the various organs and systems of the body, the marital history, the occupational history, a record of the personal habits and a personality inventory with history of adjustment to the family, school, marriage, work and community. Now, in obtaining the history of the present illness, when you are obtaining the present illness history, now each symptom should be described and expanded, and each one will have a significance. Now, the onset of the illness, like a trauma, cerebrovascular accident, they have an abrupt onset. Unlike tumors or chronic progressive degenerative diseases, they have a gradual onset. Multiple sclerosis has got remissions and exacerbations. Mostly in demyelinating illnesses, you do find that. So, these are the vascular, where the onset of the illness itself will tell you whether it is trauma or a cerebrovascular accident or it is a slow onset disease like a tumor or a degenerative diseases. Unless a bleeding has occurred to the tumor, you will not have a tumor where you find an abrupt onset. It is important to know when the patient last considered himself to be well, when he had stopped working. A patient coming to you with seizures, usually there is only one form of seizure where the patient can narrate the illness. That is the partial onset seizures or focal fits where the patient is conscious. In all the other forms of epilepsy, you find it is the patient's attender or witness who has seen who will have to describe the seizures. And that description is very, very important for a proper diagnosis of epilepsy. Except in aura, or you can say can describe an aura he might have, or it may be a focal or is a generalized tonic-clonic, and the phases in which he had it all will describe how is it an epilepsy or not. For that, the history becomes extremely important, because once you diagnose the epilepsy from the history, you find the patient will have to take a medication for almost 4 to 5 years. So, one has got to be very, very careful when you are diagnosing epilepsy, and it is diagnosed based on the history. Very, very important. And a patient sometimes presents with a headache. In such a situation, you might have certain questions asking on the type of headache what the patient has. and we have the international classification on headache, in which you find detailed questionnaires are there, we can be utilized for that. Like, do you have different types of headaches or just one? Where does it start? When did you first start having these headaches? What were you doing when the headache started? How long before the headache reached the maximal intensity? How long does the headache last? Does the headache recur? What is the pain like? Is it pressure, throbbing, pounding, aching, or stabbing? What is the, on a scale of 1 to 10? You see, 10 is worst and 1 is the least. Which would you like, what I can say, to rate the headache? And then, do you have trouble with your vision before or during the headache? Do you have any other symptoms like nausea, vomiting, light sensitivity? During a headache, would you prefer to be in the bright sunlight or in a dark room? During a headache, would you prefer to be in a room with a loud music or in a quiet room? Are the signs like fever, ptosis, meiosis present? Do you have triggers of your headache? What makes a headache worse? What makes a headache better? All these are the questions that can be asked once after the patient explains in his language all about the headache. It should be an open-ended question. Let the patient talk. Once he finishes, then you can put all these leading questions for you to have a proper diagnosis. Any over-the-counter medications that have been taken, caffeinated beverages have been taken or not, which all doctors you have seen in the past for the headache, what other treatments have you tried? Have you been under any stress lately? Have you been depressed? Do you have any parents or siblings with the similar complaints? All these things can be asked. That is, after the patient explains everything about the headache. The other things, the patient might complain about paralysis or paresis, or you say that there is a weakness of the one side of the body. So when such disturbances occur, patient or can be telling if there is a history of paralysis, paresis, atrophy. One determines the time and mode of onset. We should see whether the time and mode of onset, the location, the severity, the type and progression or improvement. If there have been any hyperkinetic manifestations as a certain of their type of nature, location, onset, duration, amplitude, frequency and exciting factors. Then inquiry also should be made regarding the weakness, fatigue, stiffness and abnormalities of the tone, clumsiness, stumbling, staggering and so on. Is there a disturbance of the equilibrium? So these are, as the patient narrates, you can also ask these questions. Vertigo, you find what you can say, giddiness, lightheadedness, and a subjective or objective signs of feeling what the patient has. And if this is present, you can ask about the nature of the mode of onset, then the frequency, severity, direction, and relationship to posture or change of position, and to inquire about the presence and laterality of the associated symptoms, such as staggering or falling. In organic vertigo, there is usually a sense of rotation, either of the individual or of the environment, and this may be accompanied by nausea, vomiting, tinnitus, deafness, perspiration and prostration. Visual disturbances, sometimes patient says there is a blurring of vision. So is there a scotoma? Is there a double vision? Is there a transient blindness? Is there any half visual field, half is gone like hemianopic fields? Then any unformed visual hallucinations are there. In auditory disturbances like tinnitus, deafness and auditory hallucinations are there or not, and are there any unsteadiness? Then other cranial nerve manifestations like sense of smell, taste, is there any alteration, lacrimation? So these are the questions that are pertaining to the cranial nerves which you are asking actually. And the disturbance of speech or expression, is it of understanding or is what you can say word output which is the problem, or can he write, can he read? Then disturbance in the sleep rhythm, sometimes people present with sleep disturbances, drowsiness, hypersomnia, attacks of uncontrollable sleep, or there may be inversion of sleep cycle. All these has got to be noted. Then visceral symptoms like thirst, appetite, disturbance of the autonomic functions. Then either there is any vomiting, is it a projectile one? Then urinary symptoms, urgency, dysuria, precipitancy, any one of those what this patient has. Besides, of course, mental symptoms for those patients who behave abnormally, like a delirium or confusion or personality change or memory difficulties. The nervous system, however, is but one part of the body, and the neurological manifestations or complications are frequently sometimes the first clinical evidence of serious systemic diseases. It's again very, very important. So, these are all aspects which you look into the present history. If the patient presents with a vertigo, you know what are the questions to be asked. If the patient presents with a visual disturbance, then what are the questions that have to be asked when the patient describes about the visual disturbance. That is what I have told you. And when these patients present with these sort of symptoms, from the past history also you have to elicit whether any similar episodes of any other illnesses what the patient had, like any history of diabetes, any history of exposure to venereal diseases, subacute bacterial enterocolitis, any history of hypertension, any history of tuberculosis, any history of any other acute infections what the patient had, and these such other history, it becomes very important. And the date, nature of illness, etc., have got to be documented very well. And symptoms referable to various organs and systems can also be inquired into, like in the present history, what I have told you. So, to elicit in the past history, depending upon which organ is involved, you can ask certain leading questions. For example, the eyes, did he have any visual difficulty? Was he wearing any glasses? And when did he change the glasses if he has been wearing it? So, any other hemianopic defects or anything which he had in the past. For the ears, was there any hearing difficulty? Was there any tinnitus? And not against that one. For the nose, any frequent allergic rhinitis or anything he had, any epistaxis he had as far as the nose is concerned. The mouth and throat, that like the colds, tonsillitis, sore throats, any difficulty in swallowing which he had. Cardiorespiratory system, like any history of asthma, bronchial asthma, history of allergy, any history of tachycardia as far as the heart is concerned, palpitation, all these things can be asked actually in the past whether you had pertaining to these organs. And in the gastrointestinal system, habits of any eating changes, habits of any frequent loose stools as well as constipation, and any heartburn, and what you can say like flatness, distension, and what you can say how is his bowel movements. All these in fact, and a dietary history can also be taken. And then history of genitourinary system, anything all that is symptoms pertaining to that, whether he had it in the past, history of any hematuria, history of any pyuria, nocturia, any urgency, precipitation, incontinence, retention or pain. And what about his sexual activity? A detailed history of that can also be taken. Then during menarche, if it's a lady, you can ask me during menarche or menopause, what are the what you can say history, what are any other associated like hot flushes or anything the patient had, or the patient had any sort of seizures during what you can say menarche, during what you can the periods. The orthopedic history, like any injuries what the patient had, any growth disturbances, any swelling of the joints, pain or redness, these can be asked. Skin, you can ask whether there was any eruptions, urticaria. So, these are organ based questions which you are trying to elicit whether the patient had any one of these problems in the past. The allergic histories, again very, very important. History of allergic rhinitis, history of sneezing, history of bronchitis, history of food intolerance, and idiosyncrasies to drugs, etc. Then of course, in the past history, and then comes the family. In the family history, you take up the marital history, the duration of the marriage, and how his children and any illness in the family per se, that also has got to be looked into. Apart from that, the occupational history is very important about what type of occupation, especially to see whether he has got any contact with toxins or heavy metals, silica, any unhygienic routines. All these things have got to be brought out, and the environment and what are the physical and mental strain what the patient had. So, apart from this family history, you look into the personal habits of the patient. Does he consume alcohol, tobacco? Does he have tobacco use, drugs, any other drugs which he is taking, then coffee, tea of excess consumption. So, all these things, and his regularity of sleep, is he a vegetarian or a non-vegetarian? Now, all these aspects, and what is the type of diet which he takes. So, this all becomes in the personal history, and the social and economic background can also be taken as in the personal history. These are the very important aspects to be taken in the family history as well as the personal history, and you do find that so from the present history we come to the past. I have already told you what are the various symptoms that we have to elicit in the past history, and then come of course the family history and then the personal history. Then it is also important to obtain some history of the cultural and economic background of the family with information as regards to the race, nativity, the length of time in this country, religion, social and economic level. Now, these are also very, very important. So, that is in brief highlighting the importance even today of taking a detailed neurologic history. Now, what I have found in my experience is when you take a proper neurologic history, you will be able to come to a conclusion of where is the lesion and what is the lesion. And the physical examination only in fact supports that view, and ultimately you find MRI or CT scan or whatever that is being taken, the modern gadgets, you find it will be supplementing that particular diagnosis if a detailed thorough history is being taken. So, that is in brief on the significance of a neurologic history that has got to be taken. Thank you very much.